That group will be tasked with the ongoing development and implementation of those key national health and medical research reforms, including the one-stop shop. And today, I'm delighted to announce the appointment of Professor Chubb as chair of that policy reform group to guide implementation. As you know, as the former chief scientist for Australia, Ian brings a real breadth of experience in science and policy development to the role. He's made an even greater contribution, though, to health and medical research through his participation himself in a life-saving clinical trial some years ago. So he has real patient or consumer experience in this area. He's been contributing to improvements in the health and medical research environment ever since. And under Ian's leadership, the National One-Stop Shop program will transform, I think, the health and medical research sector.
I retired from ANU, where I was Vice-Chancellor for 10 years. Shortly after that, I was appointed Chief Scientist for Australia for 5 years. Then I retired again, and I've been doing some interesting work that interests me since then. So I'm the Policy Secretary of the Australian Academy of Science, and in amongst it all, I chaired an advisory group on throughout a consultation period, looking at how we can improve clinical trial support in Australia. So that culminated in a report about a year ago, and the Minister had accepted the report, took it to his colleagues. The colleagues, that's to say jurisdictional health ministers, agreed to establish an Inter-Governmental Policy Reform Group, and I've been appointed to chair it.
The One-Stop Shop will deliver innovative treatments and improved health outcomes for all Australians. It will help us monitor performance. It will support health systems' sustainability, improve productivity and create jobs, building an innovation economy. I'm looking forward to a time when consumers, clinicians and researchers can easily identify up-to-date information about trials that are relevant to them anywhere in the country, and when all governments can rapidly respond to areas of need in a coordinated and strategic manner. A streamlined, harmonised, effective, predictable and consistent operating system is essential for a vibrant health and medical research sector.
The Minister talked this morning about he's been committed to delivery of the one-stop shop. He talked about having asked his department to work with states and territories on the next phase of analysis and platform specification.
So to get all the jurisdictions in line with this has been a substantial achievement, in significant part down to the work of Ian Chubb and the respect that everyone around the country has for him personally and for his work.
He also explained a little bit why I'm involved, and that is that I was a person who entered a clinical trial. I had a renal cell cancer, and I was given 3 to 5 months to live 7 or 8 years ago. And the reason that I'm still here and have enjoyed a reasonably productive and active life between then and now is because I was in a clinical trial. And what irritated me more than anything was that I hadn't thought to explore the options of a clinical trial when I was given the diagnosis. It was a surprise. There were, like a lot of people in that condition, they don't get any symptoms till late in the piece. I was asked by my treating oncologist whether or not I'd thought about participating in a clinical trial. To my irritation, I had not. When I was a younger academic neuroscientist working in a medical school integrated into a hospital, I used to have lunch on a regular basis with clinicians, many of whom were involved in clinical trials. So when it was me and I was looking at my own mortality in the mirror, it didn't occur to me to think of it. But my treating clinician did, and he referred me to Howard Gurney at Macquarie University Hospital in Sydney, and I was admitted to the trial. I was allocated to the treatment group, which was immunotherapy, and here 8 years later, although the initial prognosis was 3 to 5 months, with a bit of improvement on that if I'd undergone the standard chemotherapy. So I had good quality of life during the treatment. Bit of fatigue early when my immune system went into overdrive, but generally good. And so far, now 6 years since the treatment finished, I still have no signs of recurrence. So I was happy about that, but I was annoyed by the fact that it didn't occur to me to think about it. And so when I had the opportunity to participate in the consultation process for see if we could do better in clinical trials, I said yes, because I've got skin in the game. I benefited from it. I think if we have more clinical trials and more Australians able to participate in clinical trials, should they choose, and should they meet the criteria and all of the things that go to being admitted to a clinical trial, then that will be better for our healthcare system, and ultimately, when it's translated into standard clinical care for more Australians too. So I think my skin in the game means that I think I have some obligation to try to increase the opportunities for my fellow Australians to get access to the state-of-the-art treatments that are available in clinical trials and offered through clinical trials and ultimately through standards of clinical care. This has been a marathon for quite a while, and we're at a point that the Minister announced today where the next and important phase will effectively start. We consulted for approximately a year. There were two phases. One was, as it were, getting people's views about how we could get better, and I guess it's important to say that through that clinical trial process we saw it as an opportunity to improve. As one participant described it very early on, opportunity for transformational change, because although we can claim to be good and our standards of clinical care are good, and we do participate in a substantial number of clinical trials, the point is that we could be better. And so we were exploring, we were being advised by roughly 1,400 people both in terms of survey and face-to-face meetings with them about how we could get better. So we didn't go in saying that, this is the major problems with it, but we did go in saying, tell us how we can get better, and we got told. So we've got a good idea now about how to get better, and one of them is to build a bespoke platform that will cover site-specific approvals, that will cover TGA requirements, Office of Gene Technology regulator requirements, all of those things, with the proponents putting their data in once for processes to be parallel where appropriate and where possible, and ultimately a much more streamlined, much more efficacious system for the people who propose clinical trials. On the patient side, there will be what we've called very technically the front door, but what that is a mechanism, a portal through which potential patients can find out what trials are suitable for them, whether they're open, where they are in the country, how to get access to them if they're in a different part of the country, those sorts of things, to enable them and for their clinicians to do the same. So whomever is treating them will be able to do it easily, effectively, very efficaciously, and have a sensible conversation with the patient and say, well, this is an option, and discuss whether that's a viable option for them. The treatment's not compulsory, they're not required to participate, but when you think about life-threatening diseases, you do want to know what your treatment options are. And this is a mechanism by which they can go in armed with that information to their clinicians. Their clinicians can be armed with the information. A sensible conversation about what the options are. And that's what we want to do. So 2 parts to it: make it easier for the people who are running the clinical trials, and make it easier for the people who might benefit from clinical trials to find out what's on, where and how. We've been trying to continue to argue that it's got to be patient-centric and everything, because you also hear bad stories of people who didn't have a good experience. and that's important. You are dealing with people's health and frequently with people in life-threatening situations, but it is also about jobs. It is also about sovereign rights and responsibilities and commitments. The ethics of the whole business is critically important. I mean, it would be a pretty bad outcome to just have more of them but not have ethics and the treatment of patients as a very important consideration, indeed a primary consideration. So it has to be. There is a review of the National Mutual Acceptance for Ethics presently being undertaken, which will be built in, so that proponents don't have to go to multiple ethics committees when they want to cross jurisdictions or cross institutions, so that we can actually standardise, accredit, get proper ethics approvals conducted with all sorts of clinical trials, because there's not just the one that people have in their heads, which is, a treatment and a placebo, and let's see which is, how good the treatment is. There are all sorts of clinical trials that we need to take account of, but we also need to be able to be sure that it's not too hard, not too difficult, not too complicated, because what we wouldn't want to do is to have a situation where the rest of the world is changing what it does, and we are reluctant to change because we're reluctant to change, not because we'd be changing for the better. So we have to show it to be better. We have to show it's better for all the participants in it, on the patient side as well as the proponent side, as well as the company side, whatever the company is, and encourage more of them so more Australians get access to that state-of-the-art treatment easily and readily, and get all the information they need to be able to make a well-informed choice.
MTAA today welcomed the announcement by Minister Butler at our conference to establish an Inter-Governmental Reform Group to implement the one-stop shop for clinical trials in Australia. And this group will be chaired by Professor Ian Chubb, and this is a fantastic announcement and initiative to ensure that we can maximise the potential for clinical trials in Australia. The Value of Medtech report that was released by MTAA earlier this year shows that we have a thriving clinical trials, R&D and commercialisation environment in Australia. And with the one-stop shop to improve governance processes, to improve the approvals, and to make it easier and quicker and less expensive for clinical trials in Australia, we'll see Australia maximising the opportunities and increasing the number of clinical trials here. We already know that there's 394 clinical trials either underway or planned to commence in the next year just for medtech alone, and 71% of all medtech companies have products with some sort of local development. So this will enable greater investment in Australia and to maximise the opportunities for clinical trials. And it's a fantastic announcement, and we look forward to working with Professor Chubb and the Inter-Governmental Reform Group to implement the one-stop shop reforms.
The importance of engaging with industry underpins a lot of what we do, because we need to hear from them where they have difficulties, where the issues are too complicated, where it's overly bureaucratic, for example, and not adding value just through bureaucracy. So, there has to be some bureaucracy, obviously. There has to be forms that have to be filled, data that has to be provided, scrutiny that has to be applied. But it would be wrong to think that we just increase the burden on participants, either as patients or as proponents, and that therefore it's somehow better. So we've got to hear from them what they believe to be the issues that need to be accommodated, just as we need to hear from the patients and potential patients and consumer groups to understand what they think needs to be provided. So all in all, the one-stop shop should make it a lot more straightforward for people to be able to participate in both those two parts, the proponent side and the patient side, consumer side, and without in any way diminishing the ethical requirements or the integrity requirements of the processes. And the body that he announced that I was chairing this morning will have its first meeting on Thursday. And we have a substantial agenda. Some of it is a bit of carryover, but a lot of it is the new position that we now have to build. I like accepting responsibility. I think I have something, I have an obligation to put back. I'm here talking to you today because I benefited from a clinical trial that I first went into probably 7 years ago, maybe 8 years ago. I don't want to be one of a very small cohort that benefits, because there are other people in clinical trials now getting benefit. I would much rather see many more people having access to state-of-the-art treatment, because that's what we're really talking about. We're not just talking about another trial of aspirin. We're talking about the latest treatments, the latest medications, the latest devices that will help people live better and healthier and longer lives, and live those longer lives well. And I have insights into that if they think will be useful to them in this process, then I'm happy to deploy those insights, because I think I have an obligation to do that.